So now we'll be talking about the thyroid endocrine glands. Thyroid derived from the floor of the primitive pharynx and descend into the neck, connected to the tongue by thyroglossal duct, which normally disappear but may persist as a cyst or pyramidal lobe of the thyroid. Foramen cecum is normally remnant of thyroglossal duct. More common ectopic thyroid tissue is the tongue. Lingual thyroid removal may include hypothyroidism, if not the only thyroid tissue present. Thyroglossal duct cyst present in the anterior midline that pass move with the swallowing or protrusion with the tongue versus persistent cervical sinus leading to pharyngeal cleft sinus in the lateral neck. Thyroid follicular cells derive from the endoderm, parafollicular cells from the fourth pharyngeal box. And we have anterior pituitary, which is secrete FSH, LH, ACTH, TSH, prolactin, GH, beta endorphins. Melanocytes secreted from the intermediate lobe of the pituitary, derived from the oral ectoderm large scale spouse, alpha subunit hormone, subunit commons to TSH, LH, and FSH, and HCG. Beta subunit determines hormone specificity. We have the propneomelanocortin derivative, that is beta endorphin, ACTH, and MSH. Go pro with the BAM, that is flat peak. We have the acidophilic, that is acid peak, that is PRL and GH, whereas B flat is basophils. So mostly basophils are there, only the acidophils are PRL and prolactin and growth hormone, whereas the basics are SH, LH, ACTH, and TSH. Okay. So posterior pituitary stored and released vasopressin, antidiuretic ADH, or oxytocin, both made in the hypothalamus, supraoptic or paraventricular nuclei are transported to posterior pituitary by neurophysin carrier protein derived from neuroectoderm. We have the adrenal glomerulus, which is regulated by angiotensin II hormone, adrenocorticoid, produce aldosterone, zona classiculata, regulated by ACTH and CRH, and it hormone class is glucocorticoid, produces cortisol, zona reticularis, ACTH and CRH. Hormone class is androgen, and the produce is DHEA. We have prolactin cells like preganglionic sympathetic fibers. Hormone class is catecholamines, and production is epinephrine, norepinephrine. GFR connects with the salt melanocorticoid, sugar glucocorticoid, and sex hormone androgen. We have the alpha is glucagon periphery, beta is insulin central, and delta is somatostatin interspread. Similarly, we have the hypothalamic pituitary hormone ADH that increase water permeability on the discombobulated tubules and collecting duct in kidney to increase water reabsorption, stimulate and for secretion in increased plasma osmolarity, except as areas in which ADH is elevated despite decreased plasma osmolarity. CRS increase ACTH and MSH and beta endorphin, decrease in chronic exogenous steroid use. Dopamine decrease prolactin and TSH, also called prolactin inhibiting factor. Dopamine antagonist antipsychotic can cause galactorrhea due to hyperprolactinemia. Okay, so growth hormone is tesamorelin, used to treat HIV-associated lipodystrophy. We have GnRH, function is secreting increased FSH and LH, suppressed by hyperprolactinemia. Tonic GnRH analog nilipyrrolide suppresses hypothalamic pituitary gonadal axis. Pulsatile GnRH leads to puberty and fertility. MSH is increased melanogenesis by melanocytes, cause hyperpigmentation in Cushing disease. MCH, MCH shares the same precursor molecule, propneomelanocortin. So Cushing disease, there is hyperpigmentation. Oxytocin causes uterine contraction during labor, response for milk letdown, reflex in suckling, modulates fever, anxiety, social bonding, mood, and depression. Prolactin decrease GnRH, stimulates lactogenesis, pituitary prolactinoma, amenorrhea, osteoporosis, hypogonadism, and galactorrhea. Breastfeeding increase prolactin, decrease GnRH, delayed postpartum ovulation and natural contraception. Somatostatin decreases TSH and decreases growth hormone, also called growth inhibiting hormone, analog to economically. We have TRH that increases TSH and increase prolactin. TRH is primary to secondary hypothyroidism, may increase prolactin secretion and galactorrhea. So the GnRH is LH and FSH positive, so it is inhibited by GnRH is inhibited by prolactin. Okay, and dopamine inhibits the TSH, and dopamine also inhibits the prolactin. Okay, and GnRH, somatostatin, inhibits the growth hormone and TSH. So next is the growth hormone, so also called somatotropin, secreted by anterior pituitary, stimulates the linear growth and muscle mass through IGF, that is somatomedin C, secreted by the liver, increases insulin resistance, diabetogenic, released in pulsatile in response to growth hormone releasing hormone, and secretion increased during exercise and deep sleep, puberty and hypoglycemia. Secretion decreased by glucose, somatostatin, somatomedin, Regulatory molecules secreted by liver in response to growth hormone acts on the target tissue. Excess secretion of growth hormone pituitary adenoma may cause acromegaly adult or gigantism children. Treatment somatostatin analog like octreotide for surgery. The growth hormone inhibits the anterior pituitary as well as the GHRH. Okay, aging, obesity, and glucose inhibit the GHRH, and so growth hormone increases the amino acid uptake, increase protein synthesis, increase DNA RNA synthesis, increase chondroitin sulfate, increase collagen, increase cell size and number, increase amino acid uptake in the muscles, increase protein synthesis in the muscle, decrease glucose uptake, and increase lipolysis. So antidiuretic hormone, also known as vasopressin, synthesized in the hypothalamus, supraoptic and paraventricular nucleus, stored and secreted by posterior pituitary. Function is regulate the blood pressure BP1 and serum osmolality by BP2. And function is serum osmolality regulation. ADS decrease serum osmolality, increase urine osmolality by regulation and coupling sinusoid into the principal cells of renal collecting duct. ADS level is decreased in the central diabetic insipidus normally or increase in nephrogenic diabetic insipidus. DI can cause by the mutation in the V2 receptor, desmopressin. ADS analog is treatment for central DI and nocturnal neurosis. Regulation is plasma osmolality and primary hypovolemia. So next we have the prolactin. This is secreted mainly by anterior pituitary, structure homologous to growth hormone. Stimulate milk production in breast, inhibits ovulation in female and spermatogenesis in male by inhibiting the GnRH synthesis and release. Excessive amount of prolactin has with the decreased libido. Next is the prolactin secreting from anterior pituitary is tonically inhibited by dopamine from tuberoinfantile pathway of hypothalamus. Prolactin in turn inhibits its own secretion by increased dopaminergic synthesis and secretion from the hypothalamus. TRH increased prolactin secretion, decrease in primary and secondary hypothyroidism. Dopamine agonists like bromocriptine inhibits the prolactin secretion and can be caused in treatment of prolactinoma. So prolactinoma dopamine agonist dini. Dopamine is antagonist, most common antizygotic, metoclopramide, estrogen, OCP, pregnancy still stimulates prolactin secretion. So in pregnancy, estrogen is positive and this secretes the anterior pituitary. Okay, and from the anterior pituitary release the prolactin. Okay, and prolactin acts on the milk production. So renal failure also enhances the prolactin, whereas prolactin inhibits the GnRH, FSH, and ovulation is spermatogenesis. Decreased estrogen leads to osteoporosis, anovulation, hypogonadism, and amenorrhea. Now we have the thyroid hormone production, T3 and thyroxine. Thyroxine is T4 and triiodothyronine is T3. Iodine containing hormone that controls the body metabolism. Follicles of thyroid 5 alpha dehydrogenase converts T4, the major thyroid production, to T3 in peripheral tissue. 5-4-3. Reverse conversion is inhibited by glucocorticoid, beta blockers, and propylthiouracil. Okay, peripheral conversion is inhibited by glucocorticoid, beta blockers, and propylthiouracil. Reverse T3 or RT3 is a metabolic inactive product by the peripheral conversion of T4, and its production is increased by growth hormone and glucocorticoid. Function of thyroid peroxidase include oxidation, organification, and coupling. As MIT and DIT inhibited by P2 and methimazole. DIT plus TIT is T4. DIT plus MIT is T3. Wood-Charcot effect is protective autoregulation. Starting exposure to excessive iodine temporarily turn off the thyroid peroxidase, decrease T3 and T4 production. Function of thyroid hormone is brain growth. Okay, bone maturation, beta adrenergic effect, increase beta 1 receptor in the heart, increase cardiac output, increase heart rate, increase stroke volume. Contracting, beta blockers elevates adrenergic symptoms in thyrotoxicosis. Basal metabolism rate increase, sodium potassium ATPase, increase O2 consumption, respiratory rate and body temperature. Blood glucose increase gluconeogenesis and glycogenolysis. Break down lipids, increase lipolysis, stimulate surfactant synthesis in babies. So TRH stimulates the TSH and TSH the follicle cells. Thyroid stimulating immunoglobulin TSI and positive in follicular cells in Graves' disease. Negative feedback primarily by the T3/T4 antipituitary decrease sensitivity to TRH. Hypothalamus decrease to TRH secretion. Thyroid binding globulin binds mostly T3 and T4 in the blood. Bound T3 and T4 inactivates. Increase thyroid binding globulin in pregnancy, OCP. Estrogen increased thyroid binding globulin and increase total T3 and T4. Decrease TBG in steroid use and nephrotic syndrome. Okay, so hypothalamus is inhibited, anterior pituitary is inhibited by T3 and T4. Okay, and anterior pituitary is also inhibited by somatostatin, dopamine, and glucocorticoid. Okay, so we know all those reactions. Okay, how it is forming. At first the iodine I2 minus oxidation to converts to I2, then the thyroglobulin plus I2 is organification that forms the T's with MIT DIT coupling, that is MIT DIT T3T4, then the endocytosis, that is MIT DIT T3T4 into protease breakdown T3T4 greater than T3. So parathyroid hormone chip cells are parathyroid. So increase free calcium in the blood, increase calcium and phosphate absorption in GI, increase calcium and phosphate from bone resorption, increase calcium resorption from TCT, decrease calcium resorption in PCT, increase 125 D3 calcitriol production by activating 1 alpha hydroxylase in PCT. To make try to make D3 in the PCT. PTH increases serum calcium, decrease phosphate, and increase urine phosphate, increase urine CMP. Increase PTH, increases urine CMP. Increase Rankel L receptor activates nuclear factor kappa B secreted by the osteoblast and osteocyte, binds Rankel receptor on osteoclast and their precursor to stimulate the osteoclast. Increase calcium, bone resorption. Intermittent PTH release can stimulate bone formation. PTH is phosphate tracing hormone. So PTH related peptide functions like PTH and is commonly involved in malignancies, squamous cell carcinoma of lungs and renal cell carcinoma. Decrease serum calcium, increase PTH secretion, increase phosphate secretion, increase PTH secretion, decrease serum magnesium, increase PTH secretion, double decrease in magnesium, decreases PTH secretion. Common cause of decreased magnesium includes diarrhea, aminoglycoside, diuretics, alcohol use disorders. So we have the renal tubules, that is increasing the 125 OH to D3 and has negative feedback inhibition on PTH synthesis. PTH induced release in the circulation, PTH positive, the 1 alpha hydroxylase, okay, and it forms increases the calcium and phosphate from the bone and the intestine. Similarly, calcium homeostasis is calcium, plasma calcium exists in three forms: ionized 45%, bound to albumin 40%, and bound to anions 15%. Increase pH H plus binds albumin, binds more calcium. Decrease ionized calcium, cramps and pains, paresthesia and gallbladder spasm. Increase PTH. Decrease pH, both H plus albumin binds less calcium. Increase ionized calcium and decrease PTH. Ionized free calcium is primary regulator of PTH. Change in PTH alters PTH secretion, whereas change in albumin concentration does not. So we have calcitonin, that is parafollicular C cells of thyroid. So decrease bone resorption, increase serum calcium, and increase calcitonin secretion. Calcitonin opposes the action of PTH, not important in normal homeostasis. Calcitonin tones down the serum calcium level and keep it to bone. We have glucagon made by the alpha cells of pancreas, promotes glycogenolysis. Glucagon promotes glycogenolysis, gluconeogenesis, lipolysis, ketogenesis, elevate blood sugar level, maintain homeostasis when downstream glucose level falls to low fasting state, secreted in response to hypoglycemia, inhibited by insulin, amylin, somatostatin, and hyperglycemia. So next is insulin, that is pre-proinsulin synthesized in the RER or pancreatic beta cells, cleavage of pre-signal proinsulin stored in the secretory granules, cleaves proinsulin, exocytosis of insulin and C-peptide equally. Insulin and C-peptides are increased in insulinoma and softline areas where exogenous insulin lacks C-peptide. So its function is bind insulin receptor, tyrosine kinase activity include glucagon uptake, carry mediated and transport into the insulin-dependent tissue and gene transcription. Another effect of insulin includes glucose transport in skeletal and adipose tissue, increased glycogen synthesis, increased triglyceride, increased sodium retention in kidney, increased protein synthesis in the muscle, increased cellular uptake of potassium and amino acid, decreased glucagon release, decreased lipolysis in adipose tissue. Unlike glucose, insulin does not cause placenta. So insulin-dependent glucose transporter GLUT4 is adipose tissue in striated muscle. Exercise increases GLUT4 transpiration. Insulin-independent transporter is GLUT1, RBC, brain, cornea, placenta. Type 2 is beta cells and liver, kidney, and GI tract. GLUT3 is brain, placenta. GLUT5 is fructose, spermatocyte, and GI tract. SGLT1, SGLT2, sodium-dependent glucose transporter in the kidney and small intestine. Brain prefers glucose but uses ketone bodies during starvation. RBC utilize glucose as they lack mitochondria from aerobic metabolism. So BRICLIP is insulin-independent glucose uptake in brain, RBC, intestine, cornea, kidney, liver, islets, placenta, and spermatocytes. So regulation, glucose is the major regulator of insulin release. Increased insulin response with oral versus IV glucose due to incretins. Glucose-like peptide, GLP-1, glucose-dependent insulinotropic peptide, which are secreted after meals, and increase beta cell sensitivity to glucose. Release decreased by alpha 2 and increased by beta 2. Stimulates to insulin. Okay, glucose entered beta cells, increase ATP generation from glucose metabolism, influences potassium channels, target of sulfonylurea, and depuration of beta cell membrane, water gated calcium channel open, and calcium influx, and stimulates the insulin exocytosis. So next we have the cholesterol, ACTH and ketoconazole during the steroid synthesis. ACTH activates the cholesterol desmolase, whereas ketoconazole inhibits the cholesterol desmolase. So cholesterol is converted to pregnenolone again by 3 beta hydroxy dehydrogenase, and pregnenolone is converted to 17 alpha hydroxylase to 17 hydroxy pregnenolone. Okay, so in zona glomerulus we have pregnenolone, and in zona fasciculata we have the 17 hydroxy pregnenolone, and in the zona reticularis we have the dehydroxy, that is 17 hydroxy pregnenolone is converted to, with the help of 1720 lyase, into dehydroepiandrosterone, that is DHE. Okay, so now in the zona glomerulus what happens is pregnenolone is converted to progesterone by 3 beta hydroxysteroid dehydrogenase, and so does in the zona fasciculata. 70 hydroxypregnenolone is converted to 70 hydroxyprogesterone. 21 hydroxylase converts progesterone or the 17 hydroxyprogesterone. Progesterone converted to 11 dihydroxycorticosterone, and 17 hydroxyprogesterone is converted to 11 deoxycortisol. Next is 11 beta hydroxylation converts 11 dihydroxycortisone to corticosterone, whereas the 11 deoxycortisol is converted to cortisol. So metapone inhibits the 11 beta hydroxylase that converts the 11 dihydroxycortisol to cortisone, and cortisol is converted to cortisone. Okay, cortisol is converted to, previous was 2 was cortisol, now we convert to cortisone. So licorice or glycinic acid converts, cortisol gets increased, and aldosterone synthesis from conversion of corticosterone to aldosterone. Aldosterone synthesis is required. So corticosteroid from corticosteroid, mineralocorticoid is also formed. Aldosterone synthesis, okay, and zona glomerulus. So next on the other side we have from the peripheral tissue, and when we talk about the zona reticularis, the endostridione is converted with the help of aromatase to estrogen, and endostridione is converted to testosterone, converted to estradiol, and estromone and estradiol is converted to one another. And we have the testosterone, that is 5 alpha reductase. The alpha is finasteride, the inhibitor also. Okay, so 17 hydroxyprogesterone, we have the ambiguous genitalia in the male, and XX lacks secondary sexual characteristics. Okay, so in this increased mineralocorticoid, 70 hydroxyprogesterone, there is one is in front, so BP will increase. When BP increases, the potassium will be down. Okay, and 70 hydroxy increased mineralocorticoid, cortisol decrease in all, and sex hormone is when 17 hydroxylase is inhibited, so there will be decrease sex hormone, decrease androstenedione. Okay, so 20 hydroxy, most common one. So there is increased renin activity, increased 17 hydroxyprogesterone, most common, present in infancy, child wasting or childhood, precocious puberty, XX virilization. So here there is decrease in mineralocorticoid, cortisol is decreased in all, BP is low, and potassium is high, and okay, and 11 beta hydroxysterone. And here what happens is the there is decrease in aldosterone, but there is increase in BP, because 11 beta hydroxycorticosterone inhibition forms the 11 deoxycortisol, which has a mineralocorticoid activity. Okay, increase 11 beta deoxycorticosterone, increase in BP, so renin is decreased, BP high, potassium low, cortisol and decrease, and sex hormone increase, present in infancy, severe hypertension of childhood. So 11 beta, severe hypertension of childhood, FOC, precocious puberty. Okay, all congenital endocrine deficiencies are autosomal recessive disorder and mostly characterized by the skin hyperpigmentation due to the increased MCH production, which is co-produced and secreted with ACTH, and bilateral adrenal glands enlargement due to increased ACTH stimulation. If deficient enzyme starts with 1, it causes hypertension. If deficient enzymes end with 1, it causes vagalization in females. So next we have the cortisol. So adrenal zona fasciculata forms this, and increase in BP, upregulated 1 alpha receptor on arterioles, increase in norepinephrine and epinephrine, permissive action, high dose corticosteroid can bind to mineralocorticoid, aldosterone receptor, increase insulin resistance, diabetic, increase gluconeogenesis, lipolysis and proteolysis, decrease glucose utilization, decrease fibroblastic activity, poor wound healing, decrease collagen synthesis, increase hysteria, decrease inflammatory and immune response, inhibit production of leukotrienes and prostaglandins, increase WBC adhesion, neutrophilia, block histamine release from mast cells, eosinophilia, lymphopenia, and block interleukin 2 production, decrease bone formation, and decrease osteoblastic activity. So, bound to corticosteroid binding globulin, cortisol is exogenous corticosteroid cause reactivation of TB and candida, block interleukin 2 production. Okay, so regulation is CRH, hypothalamus stimulus ACTH release from pituitary, cortisol production in adrenal zona fasciculata, excessive cortisol decrease CRH. ACTH and cortisol secretion. Chronic stress may induce prolonged cortisol secretion, cortisol resistance, and impaired immunogenic disease of HbA axis. So, appetite regulation ghrelin stimulates the hunger, oxygenic effect, CH release by GH secretory receptor produced by the stomach, sleep deprivation, fasting, and parathyroid syndrome, increased ghrelin production. Ghrelin makes you grow hungry, acts on the lateral area of hypothalamus, hunger center, or increased appetite. You have leptin, which is satiety hormone produced by adipose tissue, mutation of leptin. Severe obesity. Obesogenic people have increased leptin due to increased adipose tissue, but are tolerant or resistant to leptin anogenic effect. Severe deprivation or starvation decrease leptin production. Leptin makes you thin, acts on the endomedial area of the hypothalamus, satiety center, or decreased appetite. We have endocannabinoids, acts on the cannabinoids receptor in hypothalamus and nucleus accumbens to keep brain areas of homeostasis and neurons control of food intake, increase appetite. Exogenous cannabinoids cause Munchausen's. Okay. So next we have the CMP followers, that is flat SAM. Okay. So CMP मा follow गर्ने भनेको चाहिँ हाम्रो कुन कुन FSH, LH, ACTH, TSH, CRH, HCG, ADH from B2, MSH, PTH, calcitonin, histamine, H2, glucagon, and GHRH. Okay. So CGMP मा BNP, ANP, EDRO, that is NO, bad think vasodilator. IP3 मा काम गर्ने चाहिँ हाम्रो GnRH, oxytocin, ADH by B1 receptor, TRH, histamine by H1 receptor, angiotensin 2, gastrin, GOTAG. Intercellular receptor we have the progesterone, estrogen, testosterone, cortisol, aldosterone, T3, T4, vitamin D. We have receptor tyrosine kinase, that is IGF-1, FGF, PDGF, EGF, insulin. We have serine, threonine, TGF beta. Non-receptor tyrosine kinase is GCSF, erythropoietin, thrombopoietin, prolactin, immunomodulators like cytokines, interleukin 2, 6, IF, and growth hormone. So that start after काम गर्ने भयो यिनीहरु. So steroid hormone are lipophilic and therefore most circulate bound to specific binding globulin, which increases solubility in male. Increase sex hormone binding globulin, lower free testosterone and gynecomastia in female. Decrease in sex hormone binding, raises free cholesterol and hirsutism. Increase estrogen, OCP, and pregnancy. Increase SHGB. So now we'll be talking about the mainly the pathology. Okay. So in the pathology we have SIADS characterized by the excessive free water retention, euvolemic hyponatremia with continued urinary sodium excretion, urine osmolarity greater than serum osmolarity. SIADS causes head trauma or CNS disorder, ectopic ADH, small cell carcinoma, lung disease, drug like SSRI, carbamazepine, and corticosteroid. Body response to increased water retention with decreased aldosterone, increased ANP and BNP, increased urinary sodium secretion, normalize of extracellular fluid volume, euvolemic hyponatremia. So very low sodium level can lead to cerebral edema, seizure. Correct slowly to prevent osmotic demyelination syndrome, formerly known as central pontine myelinosis. Treatment includes fluid restriction, first line, salt tablets, IV hypertonic saline, diuretics, ADH antagonists like convivaptan, tolvaptan, and demiclocycline. Next we have the primary polydipsia and diabetic insipidus, characterized by production of large amount of diuretic urine or thrust. Urine specific gravity less than 1.006, urine osmolarity usually less than 300 milliosmol per kg. Diabetic insipidus, diabetes is usually classified as central nephrogenic. Primary polydipsia, excessive water intake, psychiatric illness, hypothalamic lesion, affect thirst center, serum osmolarity decrease, ADH level decrease, water restriction, significant increase in urine osmolarity greater than 700. Treatment is water restriction. Central DI decrease ADH release, idiopathic tumor, pituitary, infiltrative release like sarcoidosis, trauma, surgery, hypoxic encephalopathy, serum osmolality increase, ADH level decrease, water restriction, no change or slight increase in urine osmolality, desmopressin, significant increase in urine. Desmopressin is significant increase in urine osmolality greater than 50%, and treatment is desmopressin. Nephrogenetic DI ADH resistance, hereditary ADH receptor mutation drug like lithium, demiclocycline, or hypercalcemia or hypokalemia. Okay, so increased serum osmolality, normal to increase in ADH level, no changes, a slight increase in urine osmolality in water restriction. Desmopressin, minimal change in urine osmolality. Treatment is managed with underlying cause like low sodium thiazides, amiloride, and indomethacin. So no water intake for 2 to 3 hours, followed by hourly measurement of urine volume osmolality as well as plasma sodium concentration and osmolality. Desmopressin ADH analog is employed if the serum osmolality is greater than 295 to 300 millimosmol per kg, or plasma greater than 145, or urine osmolality does not rise despite increasing plasma osmolality. So next is we have the hypopituitarism, that is under secretion of pituitary hormone due to non-secreting pituitary adenoma or craniopharyngioma. Sheehan syndrome, ischemic infarct of pituitary following postpartum bleeding, pregnancy-induced pituitary growth, increase ability to hypoperfusion, usually presents with the failure to lactate, absent menstruation, or food intolerance. Next we have empty cellular syndrome, atrophy or compression of pituitary, which lies in sella torsica, often idiopathic, common in obese female, associated with the idiopathic intracranial hypertension. Next we have pituitary apoplexy, sudden hemorrhage of pituitary gland, often in the presence of existing pituitary adenoma, usually present with the sudden onset severe headache, visual impairment, bitemporal hemianopia, diplopia due to CNS palsy, features of hypopituitary brain injury and radiation, treatment hormone replacement therapy, corticosteroid, thyroxine, steroid, and growth hormone. We have next is acromegaly, excess growth hormone in adults, typically caused by pituitary adenoma. Large tongue with deep furrows, deep voice, hand, large feet and feet, coarsening of facial features with aging, frontal bursting, diaphoresis, excessive sweating, impaired glucose tolerance, insulin resistance, hypertension, increased risk of colorectal polyp and cancer. In acromegaly, we have increased risk of colorectal polyp and cancer. So diagnosis: increased serum IGF, failure to suppress serum growth hormone following oral glucose tolerance test, pituitary nasal mass on MRI. Treatment of acromegaly, pituitary edema resection. If not cured, treat with octreotide, somatostatin analog, pegvisomant, that is growth hormone antagonist, or dopamine agonist is carbagoline. Dopamine agonist is carbagoline. This is also in children, gigantism, linear growth, heart failure, muscle cause of death. So next is we have the hypothyroidism, that is cold intolerance, decreased sweating, weight gain, decreased basal metabolic rate, decreased caloregenesis, hyponatremia, decreased free water clearance, dry cool skin, decreased blood flow, coarse brittle hair, diffuse alopecia, brittle nail, puffy face, generalized non-pitting edema, mixed edema due to increased gag in intestinal space, increased osmotic pressure, and water retention. We have periorbital edema, gastration. We have constipation, decreased motility, decreased appetite, hypothyroid myxoma, proximal weakness, increased CK, carpal tunnel syndrome, myxedema, small lump arising in the surface of the muscle when struck with a hammer, abdominal bleeding, decreased libido, infertility, hyperactivity, lethargy, fatigue, weakness, depressed mood, decreased reflux, delayed and slow relaxing. We have associated with bradycardia, dyspnea on exertion, and decreased cardiac output. Lab increased cases, decreased T3 T4, hypercholesteremia, decreased LDL receptor expression. In cases of hyperthyroidism, we have heat intolerance, increased sweating, weight loss, increased synthetic sodium potassium ATPase, increased basal rate, increased caloregenesis, warm moist skin due to vasodilation, fine hair, oncolysis, pretibal myxedema in Graves' disease, ophthalmic pathy in Graves' disease, including periorbital edema, exophthalmos, lead-like distraction, increased sympathetic stimulation of levator, palpebral, superiorlis, and superior tarsal muscles. We have hyperdefecation and diarrhea, increased GI motility, increased appetite, thyrotoxic myopathy, proximal weakness, normal CK, osteoporosis, increased fracture rate, T3 stimulates bone resorption, abnormal uterine bleeding, gynecomastia, decreased libido, infertility, hyperactivity, restlessness, anxiety, insomnia, fine tremor, increased beta adrenergic activity, increased reflex risk, okay, tachycardia, palpitation, dyspnea, arrhythmias, atrial fibrillation, chest pain, systolic hypertension due to increased number and sensitivity of beta adrenergic receptor, increased expression of cardiac sarcolemma, ATPase, and decreased expression of phospholambin, and decreased TSH, increased T3 T4, decreased LDL, HDL, and total cholesterol. We have next is Hashimoto thyroiditis, also known as chronic autoimmune thyroiditis, most common cause of hypothyroidism. So hypothyroidism, Hashimoto thyroiditis, acute, subacute granulomatous thyroiditis, serial thyroiditis, congenital hypothyroidism, and other causes. So also called chronic autoimmune thyroiditis, most common cause of hypothyroidism. The iodine deficient area as with the HLA-DR3, increased risk of primary thyroid lymphoma, typically diffuse large B-cell lymphoma. Finding moderately enlarged non-tender thyroid may be preceded by transient hyperthyroid state, thyroid oxygosis due to follicular rupture and thyroid hormone release. Serology positive with anti-thyroid peroxidase, antimicrosomal, anti-thyroglobulin antibody. Histology for the other cells, lymphoid aggregation with germinal center. Postpartum thyroiditis, mild self-limiting variant of Hashimoto thyroiditis arising less than 1 year after delivery. We have subacute granulomatous thyroiditis, also called as D-variant thyroiditis, usually self-limited, natural history, transient hypothermia, euthyroid state, hypothyroidism, often preceded by viral infection, increased ESR, jaw pain, very tender thyroid, decoherence with pain, histology, granuloma, inflammation. Next is renal thyroiditis. Renal means fibrosis, also known as invasive fibrosis thyroiditis, may present with IgG4 related diseases like autoimmune pancreatitis, retroperitoneal fibrosis, non-infectious arteritis. We have hypothyroidism, occurs in 1/3 of the patient. Fibrosis may extend to the local structure like trachea, esophagus, mimicking anaplastic carcinoma. Histology slow, enlarged, hard rock like fixed non-tender thyroid. Histology thyroid replaced by the fibrous tissue and inflammatory infiltrate. Congenital hypothyroidism, form we call cretinism, commonly caused by thyroid dysgenesis, abnormal thyroid gland development, agenesis, hyperplasia, ectopia, or dysharmonigenesis, abnormal thyroid hormone synthesis, mutation in thyroid peroxidase, iodine deficient region. So we have 6P, that is pot belly, pale, puffy faced child with protruding umbilicus, protuberance, tongue, and forebrain development. Other cause of hypothyroidism includes iodine deficiency, most common cause worldwide, typically present with goiter, iodine excess, whole sarcoma effect, drug like amiodarone, lithium, non-thyroidinase syndrome, also called euthyroid 6 syndrome, in which there is decreased T3 with normal or decreased T4 and TSH in critical ill patient. So T3 is with normal on others. Okay. So we have the hyperthyroidism. In hyperthyroidism, we have Graves' disease, toxic multinodular goiter, okay, thyroid storm, and Joe phenomenon and cause of goiter. Okay, so in Graves' disease, the most common cause of hyperthyroidism, thyroid stimulating immunoglobulin IgG can cause transient neonatal hyperthyroidism, type 2 hypersensitivity, stimulates TSH receptor on thyroid, hyperthyroidism, diffuse goiter, normal fibroblastic peritoneal myxedema, orbital fibroblast, growth ophthalmopathy, SUV T cells, lymphoblastic infiltration of retro orbital space, increase cytokines like TGF beta, interferon gamma, increase fibroblast secretion of hydrophilic GAD, increase osmotic swelling, increase muscle inflammation, adipocytes, exothermia, often present with the during stress like pregnancy, as with the HLA-DR3 and HLA-B8. Okay, so histology, tall, crowded follicular epithelium with scalloped colloids in the grapes. So we have toxic multinodular goiter, that is focal patch of hyperfunctioning follicular cell distended with colloids working independently of TSH due to TSH receptor mutation in 60% case, increased release of T3 and T4. Hot nodules are rarely malignant. Next we have the thyroid storm, uncommon but serious complication can occur when hyperthyroidism is incompletely treated, undertreated, and the patient becomes worse in setting of acute stress such as infection, trauma, surgery. Present with agitation, delirium, fever, diarrhea, coma, and trachearrhythmia, cause of death. Next, increase LFT, treat with the 4Ps like beta blocker, propanolol, propylthiouracil, corticosteroids like prednisolone, potassium iodide, lugolcyrine, iodide load, decreased T4 synthesis, or Charkov effect. We have Jod-Pasdow phenomenon. Iodine-induced hyperthyroidism occurs when a patient with iodine deficiency and partially autonomous thyroid tissue, autonomous nodule is made. Iodine deplete can help with after iodine IV contrast or amiodarone versus opposite to Charkov effect. Next is cause of goiter is smooth and diffuse when we find it's Graves' disease, Hashimoto thyroiditis, iodine deficiency, or TSH secreting pituitary adenoma. Nodular, we have toxic multinodular goiter, thyroid adenoma, thyroid cancer, and thyroid cyst. Now, when we will talk about the thyroid adenoma, benign solitary growth of the thyroid, most are non-functional, cold, and rarely cause hyperthyroidism by autonomic thyroid hormone producing hot or toxic. Most common Histology is follicular, absence of capsular or vascular invasion, unlike follicular carcinoma. Thyroid cancer, when we talk about, we have typically diagnosed with the fine needle aspiration, treat with the thyroidectomy. Complication of surgery includes hypocalcemia due to removal of parathyroid gland, transaction of the recurrent laryngeal nerve during ligation of inferior thyroid artery leads to dysphagia and dysphonia, hoarseness, induction of the external branch of superior laryngeal nerve during ligation of superior thyroid vascular pedicle may lead to loss of the tenor, usually noticeable in professional voice users. Papillary carcinoma, most common empty appearing nuclei with central clearing orphan any eye. Soma bodies, nuclear group, papillary lymphoma adopts orphan eye, increased risk with red, PTC rearrangement and BRAF mutation, childhood irradiation. Papillary carcinoma most prevalent, palpebral lymph node, good prognosis. Follicular carcinoma, good prognosis, inverse thyroid capsule and vasculature. Unlike follicular adenoma, uniform follicles, hematogenous spread is common. And so with the RAS mutation, PAX8 and PPARY gamma translocation, fine space cytology may be able to distinguish between follicular adenoma and carcinoma. Next, we have medullary carcinoma from peripheral C cells, product calcitonin, seeds of polygonal cells in amyloid stroma, stained with the Congo red, as with the MEN2A, MEN2B, and red mutation. Undifferentiated or anaplastic carcinoma, older patient presents with a rapidly enlarging neck mass, compression symptoms, dyspnea, dysphagia, hoarseness, very poor prognosis, as with the P53 mutation. Next, we have the parathyroid hormone, that is the secondary parathyroid, that is the calcium is low and PTH is high, that is vitamin D deficiency, decreased calcium intake, and chronic kidney disease. Next, we have the primary hyperparathyroidism, that is hyperplasia and adenocarcinoma. And there is primary hypoparathyroidism, that is surgical net or autonomic. Okay, and there is PTH is independent hypercalcemia, excessive calcium intake and calcium increase. And so PTH is high, means it should be at upper level. Secondary is at the left side, whereas the primary is at the right side. When you talk about the hypo, so primary hypo is on the left side, whereas PTH independent hypercalcemia is in the right lower side. Now we have the hypoparathyroidism. So next we have the hypoparathyroidism due to injury of parathyroid gland or the blood supply, usually in the surgeries, autoimmune destruction or results. So finding would be tetany, hypocalcemia, hyperphosphatemia, obstruct sign like tapping on the facial nerve, tap the cheek, or contraction of facial muscle. To assess sign, we have the occlusion of the brachial artery with BP cough, of the tricep, torpal spasm. Now next we have the pseudo hypoparathyroidism, autosomal dominant, maternal transmitted mutation, imprinting GNAS1 inactive mutation coupled to PTH receptor that encodes the GS protein alpha subunit, inactivation of the adenyl cyclase when PTH binds to its receptor. In organ resistance, kidney and bone to PTH. Finding Albright hereditary osteodystrophy, shortened of the 4-digit, short stature, round face, subcutaneous calcification, and developmental delay. There is increased PTH, decreased calcium, increased phosphate. Pseudo is pseudo autosomal dominant, paternally transmitted mutation, imprinting GNAS gene, but without end organ resistance to PTH. Due to normal maternal allele, maintaining renal responsive to PTH. Patient finding same as Albright hereditary osteodystrophy, normal PTH, calcium, and phosphate. So next we have the lab value in hypocalcemia, that is the vitamin D deficiency. There is decreased calcium, decreased phosphate, and increased PTH. Hypoparathyroidism, decreased calcium, increased phosphate, and decreased PTH. Secondary hyperparathyroidism, CKD, we have increased PTH, increased phosphate, and decreased calcium. Pseudo hypoparathyroidism, we have increased PTH, increased phosphate, and decreased calcium. Hyperphosphatemia, we have increased phosphate, decreased calcium, increased phosphate, increased PTH. So hyperparathyroidism. So primary hyperparathyroidism usually due to the parathyroid adenoma or hyperplasia, hypercalcemia or hypercalciuria, renal stone or polyuria, hypophosphatemia, increased PTH, increased ALP, increased urinary CMP. Most often asymptomatic, may present with the bone pain, weakness, constipation, abdominal pain, kidney stone, acute pancreatitis, neuropsychiatric disturbance. Ostitis fibrosa cystica is cystic bone space filled with the Brown fibrous tissue, brown tumor constitute of osteoclast and deposit hemocysteine from hemorrhage cause bone pain due to increased PTS, classical issue with the increased hyperparathyroidism. So renal osteodystrophy is renal disease, secondary tertiary hyperthyroidism, bone disease. So secondary hyperthyroidism is secondary hyperplasia due to decreased calcium absorption or increased phosphate, most often in chronic kidney disease, cause hypovitaminosis D and hyperphosphatemia and decreased calcium. Decreased hypocalcemia, hyperphosphatemia in chronic kidney disease versus hypophosphatemia with other cause, increased ELP, increased PTH. Next, we have tertiary hyperparathyroidism, refractory autonomous hyperparathyroidism resulting from chronic kidney disease, increased PTH and increased calcium. Familial hypocalciuria, hypercalcemia, defective G protein calcium sensing receptor in multiple tissues, parathyroid kidney, higher than normal calcium level required to suppress PTH, excessive renal calcium reabsorption, mild hypercalcemia and hypocalciuria with normal or increased PTH level. So next we have the diabetes, that is polyuria, polydipsia, polyphagia, weight loss, DKA, osmolar hyperglycemic state type 2, rarely can be caused by unopposed secretion of growth hormone and epinephrine, also seen in patient on glucocorticoid therapy. So chronic use non-enzymatic glycation, small vessel disease, diffuse thickening of basement membrane, retinopathy, hemorrhage, exudate, microaneurysm, basal proliferation, glaucoma, nephropathy, and nodular glomerulosclerosis. Progressive proteinuria, initial microglobinuria, AC inhibitors, and ARV neuroprotective, atherosclerosis causing hypertension, chronic kidney disease, large vessel atherosclerosis, CAD, peripheral vascular occlusion disease, gangrene, limb loss, cerebral vascular disease, MI most common cause of death. Osmotic damage, sorbitol accumulation in organ, aldosterone reduction and decrease or absent sorbitol dehydrogenase. Neuropathy, motor sensory globe stroking distribution, autonomic degeneration, GARD, gastroparesis, and diabetic diarrhea and cataract. So HbA1c greater than 6.5, impulse 6.5 reflects average blood glucose prior 3 months. Okay. So diagnosis of the diabetes is HbA1c greater than 6.5. Okay. Now fasting glucose greater than 126, fasting for 8 hours. 2 hours oral glucose tolerance is greater than 200. 2 hours after consumption 75 grams of oral glucose in water. Random blood glucose greater than 200. Presence of hyperglycemia symptoms is required. So hypercalciuria, hyperglycemia, glycosuria, increased plasma osmolarity, increased thirst. Osmotic diuresis, loss of water and sodium, hypovolemia, circulating failure, decreased tissue perfusion and coma death. So increased lipolysis, increased plasma free fatty acid, increased ketogenesis and ketonemia and ketonuria, increased anionic gap metabolic acidosis, leads to hyperventilation, Kussmaul's respiration, and increased serum lactate cause increased anionic gap metabolic acidosis and increased circulatory failure, tissue perfusion. In type 1 diabetes, we have the So now we have the type 1 diabetes, that is autoimmune T-cells mediated destruction of beta cells due to the presence of glutamic acid decarboxylase antibodies. Insulin necessary in treatment always. Age less than 30 years. Associated with obesity, no. Relative risk. Genetic predisposition relatively weak. 50% confidence in identical twins or polygyny. HLA DR3 and DR4 is associated. Glucose intolerance severe. Insulin sensitivity high. Ketoacidosis common. Beta cells number in islets decrease with decreased insulin, and classical symptoms of polyuria, polydipsia, polyphagia, weight loss is common. Histology, islet leukocytic infiltration. Type 2 diabetes, increased resistance to insulin, progressive pancreatic beta cell failure. Insulin sometimes needed for treatment greater than 40 years. So with obesity, yes. Relative strong predisposition with identical twins and polygyny. HLA no association. Glucose intolerance mild to moderate. Insulin sensitivity low. Ketoacidosis rare. Beta cells number in islets variable. Serum insulin level increase insulin but decrease in advanced diseases. We have the symptoms of classical symptoms of polyuria, polydipsia, polyphagia, and weight loss. And histology wise islet amyloid IAAP deposit. Islet amyloid बनने आए 2 मान देंगे. Diabetic ketoacidosis is insulin non-compliance or increase required due to increased stress, excessive lipolysis, increased ketogenesis from free fatty acid, ketone bodies, beta hydroxybutyrate and acetoacetate, insulin deficit and ketone present. So DK is deadly, delirium, psychosis, Kussmaul's respiration, rapid deep breathing, abdominal pain, nausea, vomiting, dehydration, throaty breath, odor due to exhale acetone, We have hyperglycemia, increased H plus, decreased bicarbonate, increased anionic metabolic acidosis, increased urine and blood ketones, okay, and leukocytosis, normal to increase serum potassium but depleted intercellular potassium due to transcellular shift from decreased insulin acidosis, osmotic diuresis in potassium, loss in urine, total body potassium depletion, life-threatening mucormycosis, cerebral edema, and cardiac arrhythmias. So treatment is IV fluid, IV insulin, potassium, okay, to deplete intercellular store, hypoglycemia from insulin therapy, hypoosmolar hyperglycemic state, profound hyperglycemia, excessive osmotic diuresis, dehydration, increase of serum osmolarity, classically seen in elderly patients with type 2 diabetes and limited ability to drink, insulin present, ketone absent, thirst, polyuria, lethargy, focal neurological deficit and seizure. We have hyperglycemia greater than 600, increased serum osmolarity greater than 320, normal pH, no acidosis, no ketones, normal to increase serum potassium and decrease intercellular potassium. Can progress to coma that if non-treated. Glucose may be required to prevent hypoglycemia from insulin therapy. Next, we have the hypoglycemia in diabetes. Usually occurs in patients treated with the insulin or the insulin secretagogues like sulfonylurea, meglitinide, in setting of high dose treatment like inadequate food intake and or exercise. Neurogenic autonomic symptoms, diaphoresis, tachycardia, tremor, anxiety, hunger may allow precipitation of decreased glucose. Hypoglycemia awareness, neurogenic neuroglycopenic symptoms, altered mental status, seizure, death due to insufficient glucose in CNS. Treatment carbohydrate, glucose tablet, fruit juice, high glucagon and IV dextrose. So that is increases the hepatic gluconeogenesis, increases hepatic glucose neogenesis, increases excretion from pancreas. So, glucagon does this, okay, increase hepatic gluconeogenesis, increase hepatic glycosanolysis, and increase secretion from pancreas. Cushing syndrome, increase cortisol due to variety of cause, increase cortisol, decrease ACTH, bilateral adrenal atrophy, most common cause is primary adrenal adenoma, hyperplasia or carcinoma, decrease ACTH, atrophy of uninvolved adrenal glands, ACTH secreting pituitary adenoma, Cushing disease, paraneoplastic, ACTH secreting small cell carcinoma, bronchial carcinoid, bilateral adrenal hyperplasia. Cushing disease is responsible for majority of endogenous cause of Cushing syndrome. Cushing syndrome, increased cholesterol. Cushing is mnemonic bio. C for increased cholesterol, U for urinary free cortisol, S for skin changes like thinning and striae, S for hypertension, I for immunosuppression, N for neoplasia, G for growth restriction and increased sugar, hyperglycemia and increased insulin resistance, amenorrhea, moon phases, buffalo hump, osteoporosis, increased weight gain and hirsutism. Screening test with increased free cortisol and 24-hour urine analysis, increased night salivary cortisol and no suppressed with other overnight dose of dextromethasone. So in 24 hours urine for the test, increase 24-hour urine cortisol, increase late night salivary cortisol or inadequate suppression on 1 mg overnight dexamethasone, measure the serum ACTH. If it is suppressed, then ACTH independent Cushing syndrome, that is exogenous glucocorticoid or adrenal tumors, consider adrenal CT to confirm. If it is ACTH is elevated, ACTH dependent Cushing syndrome, that is high dose dexamethasone suppression test. If it is suppressed, adequate suppression causes Cushing disease, whereas the no suppression ectopic ACTH secretion. Okay, CRH, we have the similar stimulation that increase ACTH and cortisol is Cushing disease. No increase in ACTH and cortisol, no increase in ACTH and cortisol ectopic ACTH secretion of CRH. So Nelson's syndrome, enlargement of pre-existing ACTH secreting pituitary adenoma after bilateral adenotomy for refractory Cushing disease, increased ACTH, hyperpigmentation, mass effect, headache, and temporal hemianopia. Treatment is transsphenoidal dissection, post-operative pituitary irradiation of residual tumor, adrenal insufficiency, inability of adrenal glands to generate enough glucocorticoid and mineralocorticoid for body need, can be due to acute or chronic. Symptoms includes weakness, fatigue, orthostatic hypertension, muscle ache, weight loss, GI disturbance, sugar or salt craving. Treatment is glucocorticoid or mineralocorticoid replacement. Pituitary adrenal insufficiency is decreased gland function, decreased cortisol, decreased aldosterone, hypotension, hypernatremic volumic contraction, hyperkalemia, metabolic acidosis, skin mucosal hyperpigmentation, increased melanin synthesis due to increased MCS, byproduct of POMC cleavage, primary pigmentation, the skin mucosa, Addison's disease, chronic primary adrenal insufficiency caused by adrenal atrophy or destruction, most commonly due to autoimmune adenitis, developing country or TB, developed country matching autoimmune adenitis, whereas developing matching TB. Secondary and tertiary adrenal insufficiency is decreased PTH secretion, secondary or decreased apathetic CRH secretion is tertiary, and no hyperkalemia, aldosterone secretion is preserved due to the function of adrenal gland intact, no hyperpigmentation, secondary Adrenal insufficiency is due to pituitary pathology. Tertiary is due to insufficiency, most commonly due to abrupt cessation of chronic steroid therapy, hypertension, and tertiary from treatment. Acute adrenal insufficiency, also known as adrenal crisis, often preceded by acute stresses and increased steroid requirement. Infection in patients with pre-existing adrenal insufficiency or steroid therapy, maybe with acute abdomen, nausea, and vomiting, altered mental status. So, Petrus-Frederick syndrome, bilateral adrenal hemorrhage, often due to meningococcemia, may present with the acute adrenal insufficiency. Okay, so measure random serum ACTH, decrease or inappropriate normal ACTH or increase ACTH. If it is decreased, is normal ACTH. Then have secondary or tertiary insufficiency, increase ACTH in the primary adrenal insufficiency. So next we have the hyperaldosteronism, that is increased secretion of aldosterone from the adrenal gland. Clinical features includes hypertension, decrease or normal potassium, metabolic alkalosis. Primary hyperaldosteronism does not directly cause edema due to aldosterone escape mechanism. However, certain secondary hyperaldosteronism like heart failure impairs the aldosterone escape mechanism, leading to worsening of edema. Primary hyperaldosteronism is seen in the patient with bilateral adrenal hyperplasia or adrenal cone syndrome. Increased aldosterone decrease running leads to treatment-resistant hypertension. Secondary hyperaldosteronism seen in the patient with renovascular hypertension, juxtaglomerular cell drain producing anheldoma, cirrhosis, heart failure, nephrotic syndrome. Next we have the neuroendocrine tumors, that is the heterogeneous group of the neoplasm originating from the neuroendocrine cells, which has a trait similar to nerve cells and hormone producing cells. Most common occurs in the GI, carcinoma, gastrinoma, pancreas, insulinoma, glucagonoma, small cell carcinoma, medullary carcinoma, thyroid, and pheochromocytoma. Neuroendocrine cells, pancreas, beta cells, endocrine cells shares a common base function through the amine precursor optic decarboxylase APUD. Despite difference in hematogenic origin, anatomical site, and secretory product, chromatin A, neuroenzyme, synaptophysin, serotonin, histamine, and calcitonin. Treatment: surgical dissector and somatostatin analog. Neuroblastoma, most common tumor adrenal medulla in children, usually less than 4 years, originate from the neuronucleus, occurs anywhere along the sympathetic chain. Most common presentation includes abdominal distension and of irregular mass that can cross the midline. Okay, wild Wills tumor, which is smooth and unilateral, less likely to develop hypertension than with the pheochromocytoma, can occurs with the obstropolous myoclonus syndrome, dancing eye, dancing feet, increased SVA, PMA, catecholamine metabolism in urine, homocyte rosette, neuroblastoma surrounding central lumen, characterized by the neuroblastoma and medulloblastoma, Bombesin, and NSE positive, as with the amplification of NMYC oncogene. Next, we have the pheochromocytoma, most common tumor of adrenal medulla in adults, derived from chromatin cells from neural crest, may be associated with the germline mutation in NF1, BHL, rate mean 2 and 2B, 10% malignant, 10% bilateral, 10% extra adrenal bladder wall organ jugal candle, 10% calcify, and 10% kill. Most tumors secrete epinephrine, norepinephrine, and dopamine, which can cause episodic hypertension. May also secrete EPO, polycythemia. Symptoms occur in spells relapsing and remitting. Increased catecholamine and meternephrines, homovandelic and vinyl mandelic acid in urine and plasma. Universally alpha antagonist, phenoxybenzaimine followed by beta blockers prior to treatment resection. Alpha blockade must be achieved before beta blockade to avoid hypertensive crisis. A before B. Phenoxybenzaimine for pheochromocytoma. Episodic hyperadrenalgesic symptoms include pressure, BP height, headache, perspiration, palpitation, and pallor. Okay, so it's 10% malignant. Okay. So next we have the all men syndromes have autosomal dominant inheritance. X-men are dominant over Williams. So pituitary, main one we have the pituitary tumor, prolactinoma, pancreatic tumor like Zollinger, Ellison, insulinoma, Vipoma, gluconoma, and parathyroid adenoma with the mutation in main one. Menin or tumor suppressor gene on chromosome 11, angiofibroma, collagenoma, and meningioma. This is main 2. That is parathyroid hyperplasia, medullary carcinoma, thyroid, neoplasm, paraphilic C-cell secret calcitonin, prophylactic thyroidectomy required. Pheochromocytoma secret catecholamine associated with the rate in codes for tyrosine kinase. Main 2B, medullary carcinoma, thyroid, pheochromocytoma, mucosal neuromas. Okay, orointestinal ganglio neuromatosis associated with the malformate habitus and mutation in red gene. So main one is 3P, pituitary, parathyroid, and pancreas. 2A is 2P, that is parathyroid and pheochromocytoma, and 2B is 1P, that is pheochromocytoma. So next is the pancreatic islet cell tumor, insulinoma. The tumor of the pancreatic beta cells, overproduction of the insulin, hypoglycemia, may see obable stride, low blood glucose, symptoms of hypoglycemia, lethargy, symptoms diplopia, resolution of the symptoms after normalization of plasma glucose level. Children patients have decreased blood glucose, increased C-peptide, exogenous insulinemic plus 10% cause as with the main one syndrome. Treatment surgical dissection. Glucagonoma is a tumor of pancreatic beta cells. Overproduction of glucagonoma with 6 days, dermatitis, glutathione migrating erythema, diabetes, hyperglycemia, DVT, declining weight, depression and diarrhea. Treatment is octreotide surgical dissection. Somatostatinoma is a tumor of pancreatic beta cells. Overproduction of somatostatin, decreased secretion of secretin, cholecystokinin, glucagon, insulin, gastrin inhibitor peptide may present with the diabetes and glucocorticoid intolerance, steatoria, gallstone, achlorhydria. Treatment surgical dissection and somatostatin analog like octreotide for symptom control. Carcinoid tumor. Carcinoid tumors arise from the neuroendocrine cells, most commonly in the intestine or lung. Neuroendocrine cells like secrete 5-HT, which undergoes hepatic phosphorus metabolism, enzymatic breakdown by mouse in the lungs. If 5-HT reaches the systemic circulation after liver metastasis, carcinoid tumor may present with carcinoid syndrome, upset flossing, diarrhea, wheezing, right-sided valvular heart disease, tricuspid regurgitation, pulmonary stenosis, and niacin deficiency. So, histological prominent rosette, proamine positive and synaptophysin positive, surgical dissection, somatostatin analog, octreotide or tryptophan hydroxylase, telotristat for symptomatic control. So, 1/3 metastasis, 1/3 present with secondary malignancy, and 1/3 are multiple. In Zollinger-Ellison syndrome, gastrin secreting tumor, gastrinoma of duodenum or pancreas, acid hypersecretion causes recurrent ulcer in duodenum and jejunum, present with abdominal pain, peptic ulcer disease, distal ulcer, distal malformation, positive secreting stimulation test, positive increased gastrin level, increased administration of secretin, which normally inhibits the gastrin release, may be associated with main one. So, in diabetic mellitus therapy, all patients with diabetes 1 should receive education, diet, exercise, blood glucose monitoring, complication management. Treatment differs based on the type of diabetes and glycemic control. Type 1 diabetes, we have insulin replacement. Type 2, oral metformin first line, non-insulin injectable insulin replacement, weight loss, particularly helpful in lowering blood glucose. Gestational DM, insulin replacement if nutritional therapy, exercise alone fails. Regular short-acting insulin is preferred over DK, IV, hyperkalemia plus glucose and stress hyperglycemia. The drug to normalize pancreatic functions are gliptins, glipes, and glipes. Okay, so biguanide or thiazidone increase insulin substitute, decrease glucose production by liver. Okay, SGLT2, that is biguanides and thiazidone increase insulin substitute and decrease glucose production. SGLT2 inhibitors decrease glucose reabsorption. Alpha glucosidase inhibitor increase glucose absorption. GLP-1 or PDE4 inhibitors are amylin analogs, decrease glucagon release from pancreas alpha cells and decrease gastric emptying. Okay. GLP-1 analog, DDP4 inhibitors and amylin decrease glucagon release from pancreas alpha cells and decrease gastric emptying. Okay. Sulfonylurea, meglitide, GLP-1 analog, DDP4 inhibitors increase insulin secretion. Insulin secretion बढाउने तर glucagonलाई घटाउने वाला भयो हैन, GLP-1 DDP4 inhibitors हरु. Okay, so now we have the rapid acting insulin 1 hour peak. Okay, so that is lispro, aspart and glucin, no lag. Okay, rapid is having no lag, that is lispro, aspart and glucin. Short acting 2 to 3 hours, regular intermediate acting. Okay, and that is regular. Intermediate acting is 4 to 10 hours, that is NPS, and long acting no real peak, that is determined or clarcin. Binding insulin receptor tyrosine kinase activity, liver increase glucose storage, function includes glycogen, fats may increase triglycerides, cell may increase potassium uptake. So adverse includes hyperglycemia, lipodystrophy, hypersensitivity reaction, and weight gain. So next we have the diabetes mellitus, increased insulin sensitivity. The biguanides, that is the metformin, inhibits MGPD, inhibits hepatic gluconeogenesis and the action of glucagon, increased glycolysis, peripheral glucose uptake, increased insulin sensitivity. So adverse includes GI upset, lactic acidosis. Okay, vitamin B12 deficiency, renal deficiency, and weight loss. We have thiazidinones, that is gliptins, pioglitazone and rosiglitazone, activates PPAR gamma, nuclear receptor, increases insulin sensitivity and level of adiponectin, regulation of glucose metabolism and fatty acid storage, weight gains, edema, heart failure, increased risk of fracture, delayed onset of action. Rosiglitazone, increased risk of MI and cardiovascular death. We have sulfonylurea, chlorpropamide and tolbutamide. Okay, So that is disulfiram reaction. First generation sulfonamide only rarely used. Second generation is glimepiride and glimepiride. Closest potassium channel. We know this mechanism. Side effect is hypoglycemia and weight gain. Meglitinides like nateglinide and dapiglinides increase glucose insulin secretion by GLP-1 analog like exenatide and liraglutide that decreases the glucagon release and increase glucose dependent insulin release, decrease gastric emptying, nausea, vomiting, pancreatitis, weight loss, and increase satiety with GLP-1 analog. DDP4 inhibitors like linagliptin, sexagliptin, and siragliptin that is inhibits DDP4 inhibitor that decreases the GLP-1, decrease glucagon release, decrease gastric emptying, increase glucose dependent insulin release. Side effects are of DDP4 inhibitors like the sitagliptin, sexagliptin, and linagliptin are respiratory tract, weight neutral, increase satiety, with decreased glucose absorption. We have sodium glucose co-transporter inhibitors, canagliflozin, dapagliflozin, and empagliflozin, drop resorption of glucose in proximal convoluted tubules. Side effect includes glycosuria, UTI, vascular vulvovaginitis, dehydration, orthostatic hypotension. Used with caution with renal insufficiency. Okay. So decrease alpha glucosidase inhibitor carbos and miglytol that inhibit the intestinal transporter alpha glucosidase, delete carbohydrate hydroxylase and glucose absorption and decrease postprandial hyperglycemia. Okay. And others are amylin analog like trimidnitide that decrease glucagon release and decrease gastric emptying, hyperglycemia, nausea, and satiety. Next we have the drug like thionamides, that is propylthiouracil methimazole. So block the thyroid pituitary, inhibiting oxidation of iodine as well as the organification and coupling of iodine. Inhibition of thyroid hormone PTU also blocks 5-dehydrogenase and decreases peripheral T4 to T3. Clinical use in hypothyroidism. PTU used in primary first trimester pregnancy. P4P. Okay, so due to methimazole tetrazonicity, methimazole used in second and third trimester due to risk of P2-induced hepatotoxicity, not used to treat grapes or thalomyopathy, treated with corticosteroid. So adverse events: skin rash, agranulocytosis, aplastic anemia, hepatotoxicity. P2 has been associated with the ANCA positive vasculitis, methimazole positive cutis aplasia. Cutis. Okay, levothyroxine or linothyroxine, that is hormone replacement T4 or T3, that is hypothyroidism, myxedema, may be abused for weight loss. Distinguish exogenous hypothyroid from endogenous hypothyroid by using the combination of TSH receptor antibody, radioactive iodine uptake, and measurement of thyroid blood flow on ultrasound. We have side effects: tachycardia, heart intolerance, tremor, and arrhythmia. We have hypothalamic pituitary drugs like conivaptan and tolvaptan, that is ADH antagonist used in SIADH. Block the action of ADH as B2 receptor. We have demiculocycline interface with ADH signal or tetracycline, okay, which is used in SIADH. Okay, desmopressin ADH analog, central DI, 1 gram factor, or sleep, neurosis, and hemophilia A. Growth hormone deficiency in Turner syndrome, also growth hormone is used. Oxytocin, induction of labor, stimulate uterine contraction, control uterine hemorrhage. Somatostatin, octreotide, acromegaly, carcinoid syndrome, gastrinoma, gluconoma, and esophageal varices. Flucortisone, that is a synthetic analog of aldosterone with glucocorticoid effect. We have the mineral corticoid replacement in primary adrenal insufficiency. So flucortisone is similar to glucocorticoid. Also edema, exacerbation of heart failure, and hyperpigmentation. Next we have the cinacalcet, that is sensitized calcium sensing receptor CASR in parathyroid to circulate calcium and decrease PTH. So cinacalcet is a secondary hyperparathyroidism in patient with CKD receiving hemodialysis, hypercalcemia in primary hyperthyroidism if parathyroid fails, or parathyroid carcinoma. Cinacalcet side effect is hypocalcemia, cinacalcet, hypocalcemia. Valemere, that is non-absorbable phosphate binder that prevents phosphate absorption from the GI tract, hyperphosphatemia in CKD, and side effect is hypophosphatemia and GI upset. Then next we have the cation exchanger reagent, that is paltiromere, sodium polystyrene sulfate, and zirconium cyclosilate. Okay, mechanism is bind potassium in colon in exchange for cations, potassium excreted in feces. Clinical use in hyperkalemia, adverse hypokalemia, and GI upset.